Recording. Okay, so good afternoon, everyone. As you can see, it's kind of a live show here of Dr. Parker and myself. We're both here in the same room. We're just chatting about the exam coming up tomorrow. So I guess just first off, to just a quick reminder, there is an exam tomorrow. It's at 1 o'clock in Urey Lecture Hall. We'll all be in the same room. You'll have Dr. Parker and myself to answer questions. We might even have an appearance by Dr. Roberts as well, in case you have any questions about his particular part of the exam. There are 50 total questions. 30 will be from the material that I've covered, 15 from the material that Dr. Parker has covered, and 5 will be from the material that Dr. Roberts has covered. There is a study guide available on Moodle for the material that I have covered that has been updated and posted. So if you have any questions about that, my material is going to end with local anesthetics. So with the lecture that we finished yesterday. So today's material will not be on the exam. So hopefully you'll still keep your ears and eyes open during this time, where this will be obviously covered on the next exam, but you don't have to worry about, again, processing all of this information for the exam tomorrow. I guess with that, I'll pause for a second to see if Dr. Parker has any announcements or additions.
For all those sections, really look for sort of central concepts. I've looked at the entire exam and feel that it's, quote unquote, straightforward. And I would take that to heart. It shouldn't take you too long to take it. There should be plenty of time. Again, make sure you answer everything. And if something looks pretty straightforward, believe it that it is. I don't think I have anything specifically beyond that. The only other thing, not non-exam related, is you've probably been seeing the announcements on the Nobel Prizes, which have been coming out the last few days. Really exciting stuff, and we can talk about that more with current event stuff in a week or two. But really momentous things. The chemistry prize, for the first time ever, went to 2 women, and that was an absolutely historical event. So anyway, there's a few more of those Nobel Prizes to be awarded over the next few days. But physiology, medicine, physics, and chemistry have been awarded earlier in the week. Very, very exciting stuff.
That's cool. Very historic. I feel like there was something else I wanted to add on to that, but now I can't remember.
It's because I went on too long.
No. Oh, I guess a point you hit upon it was, I guess overall, I think there might be some concern that there would be any type of discrepancy in terms of the types of questions that are asked or the level of difficulty that's asked between all of the instructors. As we were collectively writing this exam, we tried to keep that as homogeneous as possible. And so again, kind of like Dr. Parker said, think of general broad concepts. When I was writing my section of the exam, I was pulling directly from that study guide. There's no reason to be tricking you or making the exam more difficult than it needs to be. So it probably will be fairly similar to what you saw in that first exam. Would you agree with that?
Yeah.
Yeah. So
it's a little bit more detailed, as you get into specific drug groups like we have now compared to the first exam. Nevertheless, the general caliber of questioning is about the same between the 2 exams.
Yeah.
Hey, Tony, question. Actually,
yeah.
It's for Keith. So I had in my notes that the last 2 lectures of the autonomic were going to be on exam number 2. So are Keith's 15 questions just from those last two autonomic presentations?
Yeah, for the most part, although, and any autonomic question is answerable at this point, except for, a lot of detail on the sympathetic stuff, which we haven't really gotten to yet. Although with the autonomic square, you could answer the sympathetic questions even though you've never even covered it, because once you know the parasympathetics, you know the sympathetics. I can't remember exactly, but I suppose those last 2 few days were mostly what would be on just the PowerPoint section on parasympathetics. And you got it. And the only thing that sort of strays out of that realm a little bit is the ganglia, which of course is relevant to both sympathetic and parasympathetic. So I think there was one slide on the ganglia in which there's, a little bit of relevance, but the 5 or 6 slides in front of that are all parasympathetic stuff.
Hey, Katie, I actually had a question for you. So on the study guide, I think it's in Intro to CNSC, it says something about voltage gated channels and then the drugs that block them. When I was looking for the answers for that, after that, it was the toxins that block them. And I didn't know if you meant to know the toxins or to know the drugs.
So I guess I use the term drug kind of as an umbrella term. I consider the toxins to be drugs. So yes, I guess when I wrote drugs, I meant toxins.
Okay, I figured. Thank you so much.
Yeah. Any other questions or comments about the impending exam? No?
We'll be keeping track of email in case anything comes up in the next 24 hours.
Yeah, so we'll both be checking our emails regularly in case you do have any questions.
I'm sorry, it just took me a second to find it in my notes. So for neurotransmission, you mentioned that we'll be talking about modulatory later, but then you also have ion channels that mediate action potentials. Do you just mean like the inhibitory versus excitatory?
So in terms of synaptic transmission and kind of the primary focus will be on the main excitatory and inhibitory neurotransmitters, and then the ion channels that help facilitate neurotransmission. So your sodium, your voltage-gated sodium, your voltage-gated potassium, your voltage-gated calcium channels. So those kind of, I guess, those 3 voltage-gated channels and then the major excitatory and inhibitory neurotransmitters is what I'm going to focus on. All of the modulatory neurotransmitters, things like dopamine and serotonin, we will be covering all of that material later. So you can essentially kind of just keep that in your mind's eye, but don't necessarily focus or spend a ton of time looking at some of those slides because we are going to cover those more in depth later. So you can focus more on just those major. So focus on your glutamate, your GABA and glycine, and then everything else, again, we'll reinforce and hit upon in another section.
Awesome, thank you.
Yeah. Okay. Good, Keith?
Yeah, I think everybody just take heart. You did well on the first exam. Scored with a very high average. The average may not be quite that high, but I don't think it will be too much below it, really, on this exam. When we're done with exams by the end of the semester, I think our class average will very likely be 84, 85%.
You mind if I get started?
Right ahead, Katie. Thank you.
Okay.
Take care, everybody. Thanks a lot. I'll stick around here for a little while.
Okay. Okay, so today we'll be starting a new topic. The sedative hypnotics. Hopefully everybody is okay with this black screen. It's just a slightly different format than the previous ones. If somebody has any huge issues with this and would like me to save this as a white background and black words, that's totally fine. I'm happy to do that. But I just thought with sedatives, this kind of was an appropriate kind of backdrop. As always, I like to point out which chapters this material is in relation to the textbooks. So Katsung is chapter 22 and Goodman and Gilman is chapter 19. Again, all of the materials that are presented here are found within those 2 textbooks within those chapters. What's interesting is that today is actually a great class to have prior to an exam with this particular topic, just because so many of the drugs that we'll be talking about today overlap with some of the other, I guess, chapters that we've discussed previously. So we'll be talking a lot about benzodiazepines, which we've hit upon previously, barbiturates, which we've hit upon previously. And so there's, again, I think some reinforcement of some items. And then we'll also talk about the GABA A receptor, which, hits upon several other chapters that we've talked about previously, the neurotransmission, central nervous system chapter, as well as some of the anesthetic chapters that we've discussed as well. Yeah.
Everybody, I'd like to say I'm prejudiced, of course, but I think this is the single most important topic that we cover all semester and next semester. The sedative hypnotics are just an incredibly important group of drugs and have relationships to other things, as Katie was talking about. So this is really a great area.
Yeah, of course. Sorry, I just wanted to open up my chat. Okay, so I guess we should begin by kind of defining exactly what falls, or how do you define a sedative or hypnotic? So sedatives generally have a couple different effects that fall under their umbrella. They should essentially reduce anxiety and exert a calming effect. We'll talk about how some of them also induce sleep. So a hypnotic drug should also produce drowsiness and encourage onset of maintenance of in the state of sleep. So it's not surprising, given both of these kind of, I guess, requirements to be a sedative hypnotic, that some of the drugs that we'll be talking about we've discussed previously, because again, at lower concentrations could be used as a sedative hypnotic, and then at those higher concentrations can be used as anesthetics. So there is a graded dose-dependent depression of CNS found with these drugs. You can see here, this chart shows an interesting difference between drug A, which is probably more of the drugs that have been used historically, where as you increase your dose, you see a linear relationship with the effects on the central nervous system. So especially even at those higher doses, you're able to hit that the coma state pretty rapidly with an increasing dose. What's interesting is a lot of the new drugs are falling into category B, where you have to increase that dosage significantly to even reach that level of coma. So with drug B, you kind of see that curvature at the top, where those drugs are, I think, maybe a little bit safer in their administration, because you're not inducing things like coma, but you are able to increase the dose to an anesthesia point. So again, there's going to be a lot of overlap with the drugs we've talked about previously and here, and often it's a dose-dependent relationship between whether they're used for sedation or hypnotics or sedative purposes, or whether they're used for anesthetic purposes. Okay, so as I alluded to, we've discussed many of these different drug classes in the past. This particular figure is nice just because it actually shows you the structure of the benzodiazepines. What's nice about this chapter too is it kind of talks a little bit more about the chemistry of these different drug classes. So for example, the benzodiazepines you can hear are these grouped in these 7-membered heterocyclic ring structures. Again, the 7 position, in order for it to have that hypnotic sedative effect, there is a substitution with a halogen or a nitro group. So you can see the halogen group is substituted in a majority of these drugs. And then with niazepam, you see that nitrogen nitro group. And then just kind of a quick note down here is just about the metabolism of benzodiazepines. We're going to talk about the metabolism and the pharmacokinetics of all of these drugs kind of extensively throughout this particular presentation. But again, this is just a nice big picture just showing, again, the overall structure of the benzodiazepines. As we've talked about previously, their main target is that GABA A receptor. The GABA A receptor is an ionotropic receptor. We're going to talk about that, look at the structure of it, and about how the activation of that GABA A receptor leads to an opening of the ion channel that allows chloride to flux into the cells and cause essentially depression of the postsynaptic cell. But again, we'll talk more about the neuropharmacology here in another few slides. Okay, so in terms of essentially the biotransformation of benzodiazepines and essentially how they're metabolized, there's you have phase 1 and phase 2 reactions. And so in the phase 1 reactions, you have microsomal oxidation by the cytochrome P450s, specifically the CYP3A4. It's interesting to note with benzodiazepines, there are some metabolites that have a fairly long half-life. And so that can actually convolute some studies and research as to the effects of the benzodiazepines, because you have those metabolites that are hanging out in the system that also can produce the same type of reaction. And so it's almost like you have a contamination of not just the original benzodiazepine that's been administered, but also the metabolites of the benzodiazepine, maybe that had been administered hours before. So that's the type of phase 1 reactions. And phase 2 reactions, they're conjugated to form the glucuronides, which are excreted in the urine. And so this figure down here actually does a nice job of kind of combining all of the phase 1 and phase 2 reactions that you can see of each one of the benzodiazepines. Here you see that conjugation that can occur, and then eventual urinary excretion. So it's kind of a fast ADME rundown there. What's interesting to note too, as we're talking about the pharmacokinetics of the benzodiazepines, you can kind of see a nice table that includes some of the Tmax as well as half-lives of these drugs. This table includes not just the benzodiazepines, but some of the newer hypnotics that we'll talk about in a second. So it's almost like a nice compare and contrast of the pharmacokinetic timelines of each of these drugs. Okay. The barbiturates, again, you can see some of the structural differences, how they vary from the benzodiazepines. Again, you're not seeing as not all cyclical structures, but some. They are going to be processed by hepatic enzymes. The elimination half-lives of some of these barbiturates are fairly long. Phenobarbital is worth noting that the half-life is 4 to 5 days. And then in terms of the excretion, roughly 20 to 30% of it is excreted unchanged in urine. So that's kind of an exception to the rule in terms of the metabolism for barbiturates versus when we're comparing and contrasting barbiturate metabolism with some of the benzodiazepine metabolism that we just looked at. And so I've also included some of the hepatic metabolic inactivation that you can see here. So you can actually see some of the structural changes that occur to barbiturates during the metabolic process. So I've actually gone through a few slides. I'm just going to pause there to see if anyone has any questions or to see if Keith, if you have anything to add.
No, I think you're doing great.
I had a question.
Mhm.
So you mentioned that you needed a halogen or a nitrogen at the 7 mark. So for some effect, but does it have any effect if it doesn't have it, or is that needed to bind to the receptor?
That's a structural component that's required to bind to the receptor, so it has activity. So if it's lacking that substitution, you won't see as high affinity interaction with the GABA A receptor.
Okay, so since we don't have like a lot of halogens naturally for the endogenous thing that binds to it, is it a nitrogen that's there instead?
Well, it's not binding to, so the as we'll talk about here in a second, the benzodiazepine binding site is actually separate from the normal GABA binding site. So it's a different part of the GABA receptor that it's binding to. And do you think, are there any endogenous ligands that bind to the benzodiazepine binding site, do you know?
I suppose in a dose-related sense, some may, but in terms of sort of normal concentrations, I don't think there's much.
Yeah, again, because you're not hitting that like the endogenous ligand site, you're hitting a site on the receptor that's varied from that.
Okay, so there is no endogenous ligand that we know of that binds to the benzodiazepine place.
Yeah, so that's kind of what I was asking Dr. Parker, and off the top of my head, I can't think of one.
That's long been argued, all right, and sought after, but it's still an area of investigation.
To be
He's a little hard to hear. I'm sorry.
Oh, okay. Dr. Parker said that it's still an active area of investigation.
Okay.
So I guess currently people are still looking for endogenous ligands. And that actually brings up a really interesting point. We talk about receptors and things that bind receptors and the role of endogenous ligands that are unknown for a long time. I think probably the cannabinoid receptor was one that finding the endogenous cannabinoids was, and opioids was long sought after, a hotbed of academic research. And so the idea that there are these receptors that bind to things that these known drugs, but we don't know what naturally in the brain or the endogenous ligands are. It's not surprising that that's also the case that we're seeing here.
Okay, thank you.
Yeah. Okay, so again, benzodiazepines and barbiturates. Can you hear me better if I throw my mic in? Otherwise, I'm not going to do it.
No, it's the same.
Okay, regardless. Okay, again, benzodiazepines and barbiturates are probably more the classical hypnotic sedatives. There's a newer class of sedatives that have been developed. So here you can kind of see the structures of each of those. And you can see, I guess, some structural overlaps with what we've seen, specifically probably with the benzodiazepines. The newer hypnotics, this information is kind of spread throughout the chapter, but I wanted to bring it all together onto a single slide so you can see, what kind of chemical structural class each one of these fell into, and then also a little bit of ADME about the newer hypnotics as well. So it's interesting, zolpidem, the peak plasma is in 1 to 3 hours. It's metabolized by the CYP3A4. Zapolon is metabolized by hepatic aldehyde oxidase. And I think that R shouldn't be there. It's a CYP, and some of it is also metabolized by the CYP3A4. And the dosage is essentially reduced for hepatically compromised individuals and for the elderly. And that's a kind of a common theme that we see. If the sedative or hypnotic is being hepatically metabolized, if the individual is compromised in some way, you're going to have to alter dose. And also in an older population, you'll also have to alter dosage for these drugs. So what's interesting too is in those patient types, in some of these drugs, you also see that there is a prolonged elimination. The metabolism isn't occurring obviously as quickly as would otherwise be expected. And so you see a prolonged drug action in that instance. There are a couple other kind of newer hypnotics that are just kind of briefly mentioned in a single sentence that I just wanted to throw up here just because they have different targets. Ramelteton and tasimelteton are melatonin receptor agonists, and then sergilvexant is an orexin antagonist. And again, if you think about what we're trying to induce here, we're trying to induce sleep or sedation, low levels of sedation. And so it's not surprising that these other targets that we're talking about here have also been targeted. Melatonin is often sometimes taken by individuals to increase sleep, and then orexin also kind of has that same role in sleep induction. Okay. Again, this is kind of that same table that we looked at earlier, just running through those different benzodiazepines that we saw previously. And then you can also compare and contrast some of the pharmacokinetic time points of these newer hypnotics that we just went over. And so you can see that some of the newer ones, again, might have a slightly longer or a shorter half-life than some of the older ones. It just kind of, again, depends on the nature of the drug and the structure and how it's being metabolized in the body. When we talk about pharmacokinetics, kind of, we just did a laundry list of describing the pharmacokinetics of those previous drugs. Not surprisingly, I think we've hit upon this multiple times when we're talking about absorption. Lipofacility is going to very much affect how the drugs are able to access their regions of interest. Obviously, many of these sedative effects, you want them to affect the central nervous system. So for them to be very lipophilic, they can get right past that barrier and affect the central nervous system. It's also important to recognize here that many of these drugs also cross the placental barrier and then are also bioavailable in breast milk. And so there's something to take into account with, mother, I guess, pregnant women or new mothers as they're possibly being prescribed any of these sedative or hypnotics. They must be metabolized to the water-soluble form in order to be excreted. Some are excreted unchanged in urine, and so kind of the exception that we saw to that previously was phenobarbital, and again, that was at roughly that 20 to 30% of it remains unchanged. As we discuss pharmacokinetics, and I think this is probably true for the pharmacokinetics of many drugs, things like age, hepatic disease states, drug-induced increases or decreases in enzymatic function of CYPs is going to alter the way that these drugs are processed. So if you think back to when we were talking about alcohols and the effects of chronic chronic alcohol usage on some CYP enzymes. Some of them saw upregulation with chronic alcohol use. Wink, wink, nudge, nudge. You might see a question like that similar onto the exam about what chronic alcohol use does to specific enzymes. But again, that kind of brings together that previous material that we talked about in this material, how chronic alcohol use can increase enzymes and how those enzymes have multiple substrates. And so some of these substrates fall into this sedative hypnotic category. Again, I tend to talk kind of quickly. I'm going to pause again and see if anybody has any questions or if Keith has anything to add.
I have
Just
a
to note
question.
that substances like melatonin and the orexins will cover again when we do the hormonal section late in 444.
Oh, okay. So yeah, so the orexins and melatonin will be covered in 444 as well. We get to hormones. Sorry, Sydney, didn't mean to interrupt you. What was your question?
So I know that all of these drugs kind of cause drowsiness, but how do you decide if you're going to use one for anxiety versus for sleep and then only for sleep?
So I think I think they're going to have essentially dose dependent effects. And so it just kind of depends as to the dosage that you want to use. And then it's also, we're not getting into the weeds of talking about different subtypes of GABA receptors, but there is going to be, we're going to talk about the GABA A receptor kind of as a one uniform receptor, but there are also different compositional subunits of the GABA receptor that's going to affect the affinity and location expression of it. And so some of these drugs are going to have a slightly higher effect in kind of the regions of the brain that are responsible for sleep and other regions of the brain that are responsible for anxiety. But I think we're not necessarily going to get down to that level of nitty gritty at this point. But I think some of them do have a higher affinity depending on the composition of the GABA receptor and their specific interaction. Do you have anything to add?
Just, how disinhibitory the drugs are. The more disinhibitory they are, the more likely that they're to be used for anxiety purposes and compared to some other things. That's all I can think of saying. Okay,
and that actually I think leads really nice into this this next slide, which is a molecular pharmacology of the GABA A receptor. So we've kind of hit upon, I think, a couple different questions that have been asked, kind of about, okay, well, where exactly are these drugs acting? How is it interacting with the endogenous ligand? And so if we look at the GABA A receptor, you can see that it's pentameric, meaning that it has 5 subunits. It's generally composed of 2 alpha, 2 beta, and a single gamma subunit. Again, within those alphas and gammas and what have you, there are multiple different subtypes of each one of those compositional units, and that's going to again alter the way that these drugs interact with the GABA A receptor. But if we can kind of just look at like a prototypical GABA A receptor, this is kind of the composition of it. Generally, it's 2 alpha 1, 2 beta 2s, and 1 gamma 2 subunits. And if we look at, again, this kind of cartoon representation of the GABA receptor, you can see that there are 2 GABA sites that are presented here. You can see that they're sometimes at those junctions of the multiple subunits, and that you can see that outside of where the endogenous ligand binds is where you have the site of action of things like benzodiazepines, flumazenil, and then zolpidem are all kind of located there, kind of tucked between that alpha and that gamma subunit. It's also interesting to note that the barbiturates have a separate binding site outside of both the benzodiazepine binding site and the GABA binding site. So again, you can think of these as allosteric binding sites, right? They're not competitive agonists. They're not competitive antagonists, obviously, but they're not competitive agonists for that endogenous ligand. They have their own separate binding site that's affecting essentially the way that that particular receptor functions. So in the case of GABA, the benzodiazepines are actually going to bind to the receptor and actually increase the length of time in which that receptor is open and allowing chloride to flux into the cell. So that's essentially almost like a positive allosteric modulator because it's allowing for the opening of that particular receptor and for a longer period of time for that chloride to influx into the cell. So as that chloride's influxing into the cell, it's making that cell far more negative. And because of that, it has that inhibitory effect. It's far more difficult for action potentials to be elicited in cells that have that far lower resting membrane potential that's affected by, or not resting, but that membrane potential that's been hyperpolarized by the influx of chloride. This kind of slide kind of continues, again, kind of that same point, very similar image that you see here. And you can see, if we look kind of the top down view of the GABA-A binding sites, GABA is binding at the junction between the beta and alpha subunits. And then here you can see the benzodiazepine site is at a separate junction between that gamma and alpha site. As I kind of talked about in the last slide, this does cause neural inhibition, allows chloride influx into the postsynaptic cell, increases the duration of channel opening, and leads to inhibitory postsynaptic potentials, or a hyperpolarization of that cell. What's interesting to note is that barbiturates are able to bind to both GABA-A receptors, but then they also have a secondary action at the AMPA receptor as well. And so it acts as an antagonist to the AMPA receptor. So if we remember what the AMPA receptor does when we're talking about intra the CNS information, AMPA receptors are important for excitatory neurotransmission. So if barbiturates are acting as an antagonist, it's essentially dampening neural function in two different ways: by dampening the excitatory, and by essentially causing more of the inhibitory action by interacting with the GABA-A receptor. Okay. Keith, they're saying that they can't hear you. So next time, if you have comments, I'll mask up and you can come closer. Does that sound good?
Well, I'm just trying to socially distance.
I know. Well, I can hand the computer off to you as well. I'll just unplug everything. So next time Keith has something to add, I'll unplug the computer and hand her over. Okay. So this is, again, just kind of an extension of the conversation we're having about different drug action sites and what happens at the GABA-A receptor. So what's nice about this particular slide is it's showing some of the other sedatives that are not necessarily binding to the benzodiazepine binding site. Some of them are, in fact, agonists. There are also antagonists when we talk about toxicity or over-administration of things like benzodiazepines. There are antagonists that are used to essentially combat the benzodiazepine toxicity that's observed. And so flumazenil is going to be the antagonist. Again, it's, if you read in the chapter, they say that this has to be done in a highly supervised environment, just because the concentrations of these two drugs are going to be important to kind of keep within that therapeutic index as much as possible. And then lastly, down here, there are some inverse agonists, or ultimately negative allosteric modulators, that also can combat the effect of the sedative hypnotics if need be. So this is, again, a nice review slide because we're talking about things like agonists, antagonists, and inverse agonists. When we talk about benzodiazepines, they fall not necessarily into any of these categories. They're almost their own category of positive allosteric modulators that are able to, again, increase the opening time of the GABA receptor. Okay. So I guess in terms of the overall kind of organ level effects of the sedative hypnotics, obviously one of the greatest effects that that's going to occur is sedation. So as these drugs are administered, you're going to see that level of sedation increase in a dose-dependent way. They also act as hypnotics, as we saw when we were talking about their use as anesthetics. Obviously, as you reach the upper end of those dosage curves, you are able to use them in an anesthetic way. Benzodiazepines in particular are used as anticonvulsants. Again, that interplay between excitatory and inhibitory neurotransmission. Because excitatory neurotransmission, generally convulsions are a result of overexcitation of the central nervous system. If you're able to activate or kind of activate those brake cells that are going to cause the influx of chloride, that starts to result in a slowing down of those convulsions, and you can combat that. Again, you don't want to overdose though, and then have that negative side effect of creating comatosis. They can also be used for muscle relaxation. Again, you're dampening down any type of peripheral neurotransmission as well. And then there are some effects that are seen on respiration and cardiovascular function. So they can be used to depress those as well. Again, this is a very brief kind of overall explanation of some of these organ level effects. We've hit upon these topics, repeatedly over the last week or so. So I didn't necessarily want to go into like a ton of explanation here, just because we've talked kind of about both the benzodiazepines and barbiturates for their anesthetic and sedation types of properties. Okay. So what's interesting to note is that there can be tolerance when these drugs are used over extended periods of time. And so ways in which that tolerance kind of is generated is through a series of possible mechanisms. One, you could have an increased rate of metabolism. So as we talk about with any drug, like we talked about with alcohol, as you have chronic exposure to a specific I say stimulant very loosely here. When you have chronic exposure to a ligand, your body is going to try to metabolize that at a greater rate. And so you're going to see an upregulation of those enzymes. And so, for example, barbiturates are a great example of that, where chronic exposure can increase those enzymes and you'll have an increased rate of metabolism of those drugs. With benzodiazepines, that's what benzo stands for here, you can have a downregulation of receptors. And so if those GABA A receptors are seeing repeated stimulation, that essentially the way your cell is going to respond in order to maintain homeostasis is to pull those receptors off of the surface. And so you're not getting the same level of activation that you were seeing prior. And so in order to compensate for that, you have to increase the dosage of the benzodiazepines so you can saturate all of the existing receptors on the surface. They are, because of this, because of their sedative effects and their hypnotic effects, they are compulsively misused, and so tolerance is seen pretty frequently. And because of that, they're essentially categorized as Schedule 3 or Schedule 4 drugs. When we're talking about tolerance and dependence, I guess it's also important to talk about what happens during withdrawal. And so withdrawal is going to depend on a variety of things. One is going to be the half-life of the drug itself. So the longer the half-life of the drug, essentially the less severe the withdrawal is. If the half-life of the drug is very short, then as soon as it is no longer in the system, that withdrawal is going to be fairly severe. So with that in mind, sometimes the drugs that have a longer half-life are used to almost kind of wean folks off of those shorter half-life drugs. Again, that's one of the therapeutic uses of some of these sedative hypnotics, again, is by kind of switching one out for the other. So the same mechanism is essentially getting excited, so you still have that same level of depression, but the withdrawal status of the interplay of those two, of that drug, isn't going to be as severe or as severely felt by the physiological system as otherwise would be. Okay. Okay, just glance back at Keith, see if he had anything, but I think he's figuring that maybe it's almost too complicated. So in terms of treatments outside of just sedation, often these drugs are also used for anxiety states. And so when we talk about anxiety, it's nice to kind of define exactly what that looks like or how it presents. So anxiety can take many forms, but will often present itself as this enhanced vigilance, motor tension, autonomic hyperactivity. And so benzodiazepines are often used to treat some of the acute attacks of these anxiety states. When we were talking about benzodiazepines and kind of their advantage of using them as anesthetics, again, they're often used in preoperative care because they can decrease the anxiety levels of the individuals. And so it's part of that whole anesthetic treatment plan is to start with the benzodiazepine because of this overlapping effect that it has with anxiety. Often people are going to be more anxious if they're going into surgery. It has a relatively high therapeutic index and minimal effects on the cardiovascular autonomic functions. But the downside to using these chronically for an elevated anxiety state is that level of dependence that we just talked about. You know, CNS depression. Once you do stop using, obviously you have to worry about the withdrawal that we just spoke about, and the amnesic effects of the benzodiazepines as well. So I guess a point we'll kind of hit upon again and again here when we're talking about this particular class of drugs. It's important to recognize that extreme caution should be taken when they're being co-administered with other central nervous depressants. And so other depressants that we've already talked about are alcohol. We've briefly mentioned antihistamines, and we've talked a little bit about anticholinergics. So anything else that depresses the central nervous system, it's again, it's worth noting in a patient's history if they are taking these other CNS depressants and taking that as part of your, your possible prescription path for the use of these hypnotics or sedative hypnotics. So again, when we talk about the two applications and uses, one is for anxiety. So I talked a little bit about the use of benzodiazepines there, and then also for the treatment of sleep issues. Again, there's also, this is an area that you have to worry about chronic misuse. We talk about the molecular mechanism. Interestingly, benzodiazepines can cause REM and slow wave sleep. Some of the newer hypnotics aren't necessarily as effective in that deeper sleep induction that we see with benzodiazepines. I think generally when people are looking for treatment of a sleep issue, they're looking for things that are going to induce sleep rapidly, that you're going to be able to stay asleep, and that there's not going to be any type of hangover. So if there's no amount of brain fogginess that's kind of continuing to plague the individual after they've essentially come out of their self-induced sedation. Those newer hypnotics that we talked about there with the orexins and melatonin, again, that you'll hit upon more in 444, are also, I think, common drugs that are used for sleep induction. Again, the molecular pathway, it makes sense with the molecular pathways. We'll talk about those more when we're talking about hormones. Okay. Other therapeutic uses that we have discussed here, we've obviously discussed kind of at length their uses as anesthetics, again, how that all occurs in a dose-dependent manner, again, discussed. For withdrawal treatment, so there I've discussed previously how, some of these sedative hypnotics with a longer half-life are used to treat some of those shorter half-life sedative hypnotics. And then we've also briefly hit upon their usage as muscle relaxants. Again, anything that depresses central or peripheral nervous system action is going to allow for a depression of excitation and for a relaxation, whether you're talking about brain activity or whether you're talking about innervation into muscles as well. Okay. So again, not surprisingly, I think as we talk about pharmacology and toxicology, I think in the toxicology department, I guess the poisons in the dose is I think what you've often heard. And so this class of drugs is also falls under the kind of that same statement. So it's toxicity is obviously dose dependent. So it's when we take into account benzodiazepines and barbiturates, they're often used for deliberate overdoses. And so there's people are looking at their sedative effects and think that they take enough of it, you can induce things like coma. Flumazenil, which we talked about before, that's the antagonist to that benzodiazepine binding site. And so that's going to aid in the reversal of those toxic side effects. But as you're treating with this antagonist, it's important to keep your eye on respiration. You don't want to become too respiratorily depressed. And so again, as I kind of mentioned briefly before, it's important that this is done in a highly supervised environment because you're interacting, the concentration interactions between an agonist and an antagonist, that's a very careful interplay that has to happen. And for individuals that are hypersensitive to the benzodiazepines and barbiturates and any of the other sedative hypnotics, usually kind of comes about as rashes or presents as rashes. Okay. So we've kind of already hit upon some of the effects of tolerance, how it's going to affect. So I guess there's this idea that if you generate enough tolerance, you can actually avoid lethal dosages, and that's in fact not true. You can't avoid a lethal dosage. That point's just essentially there. Dependence can develop, not surprisingly. So you're essentially activating the inhibitory system in your brain. So after an extended period of time, we talked a little bit about how those receptors are going to respond. And so because of that, in order for your body to reach homeostasis, it's going to require this activation. We've talked about withdrawal previously, but kind of how that symptomatically presents is with things like restlessness, anxiety, orthostatic hypertension, and then if withdrawal in severe instances, again, is seizures. And so with those shorter half-life drugs, again, if you discontinue them, a lot of you'll see those more severe side effects happen more rapidly than you would with those slower half-life drugs. But can use a cross dependence, and I kind of keep alluding to that idea, the ability of one drug to suppress the abstinence symptoms of another. So again, interplaying with those different half-lives of those different GABA A agonists. Okay. So it's just important to recognize with these sedative hypnotics, do not co-use with any other type of CNS depressant. There can be cumulative effects because of that. So things like alcohol, opioids, anticonvulsants, all are going to have this additive effect to any of these sedative hypnotics that you take. Antihistamines, antihypertensive, antidepressants, those might be, I guess, not as I guess clear or apparent to ask patients about those other drugs that they might be taking, but definitely still relevant, again, because they're still causing that CNS depression and are going to have an additive effect between, are going to have an additive effect of the sedative hypnotic with the other CNS depressant. Okay. So would tolerance lead to a more narrow therapeutic window? I don't necessarily know if tolerance would necessarily lead to an alteration of the therapy. Are you talking about the therapeutic window for the antagonists or for the slower half-life drugs?
I was thinking, so since for this single patient, so within a single patient, they need more of the drug to get a therapeutic effect, but they can still overdose. So would their toxicity levels still be the same? So they're just getting a more narrow window, or would their toxicity level increase as well?
Their toxicity level remains unchanged. So you still have that maximum point that you're going to see toxicity. But I think you're right in that assumption that the therapeutic window is going to be much lower because they've built up that tolerance, because you're going to need a lot more drug to kind of get to that very narrow range in which they can hit before they hit that ultimate toxicity.
Okay, thank you.
What are we doing on time here? Oh, getting close. Okay, well, perfect timing today. So the final thing that I have for you, we have about 2 minutes left, so I'm going to let you kind of chew on this, and if anybody wants to give me their answers. So a 35-year-old woman comes to her physician complaining about not being able to sleep for the past week. She is prescribed Zolpidem to be taken at bedtime. And the questions I have for you is what type of drug is Zolpidem, and what is the mechanism of action, and what side effects should this woman be warned of? We're essentially at 1:48 now, so if you want over the next few minutes, go ahead and process this and private message me your answers as you come up with it. And also, kind of as you're processing this particular question, also be thinking of any other additional questions you might have about the material for Keith and I, as we're both here and happy to answer whatever questions you might have. Okay. So we've officially hit 150. Don't want to rush anybody through this particular question. I've received a few answers from folks that look right on. So it's a GABA A receptor and agonist. Some of the side effects that this person should be warned of are things like sleepwalking, drowsiness, headache, daytime drowsiness as well. This particular slide, I think, goes through a majority of what we're hitting here. But it is a nice review again of exactly kind of how you would describe this particular drug as a GABA A agonist, and then also kind of some of the effects of this. What's nice about this answer that's provided here, it also talks about things like therapeutic dosage, as well as kind of the long-term depressive effects that this particular drug might have if administered. It has a particularly long half-life. Okay, so that's all I have for you today on the sedative hypnotics. I've been able to cover a good portion of what's in Goodman and Gilman and Katzung. So I think we're back on track in terms of schedules for next Tuesday. Don't forget you have an exam tomorrow. Good luck on the exam. If you have any questions, feel free to reach out to Dr. Parker or myself, and we'll be happy to answer them to the best of our abilities. And I think that's all we have for you today. So thank you so much and have a great day.
Great lecture. What a topic. Important. They're so